I'd like to introduce Dr. Brad Summer, who's going to talk about colorectal cancer this morning.
Today we'll be discussing colorectal cancer. We will walk through how to stage this disease, then talk about adjuvant therapy, including stage 3 disease, differentiating between stage 2 high risk versus low risk and the role of adjuvant therapy. And then we'll be discussing neoadjuvant therapy in rectal cancer. And then we'll walk through the treatment of metastatic colorectal cancer, including the use of chemotherapy, biologicals, and how treatment decisions are made in addition to common drug toxicities with these drugs. We won't discuss early detection or screening. We will touch on familial syndromes and imaging, and we won't really be discussing much on liver resection or curative treatment for stage 4 disease, and we'll really touch on rectal cancer. If you look at the epidemiology of colorectal cancer, it's the fourth most common cancer diagnosis in the United States, accounting for approximately 137,000 new cases a year. Generally speaking, the male to female ratio is 1 to 1. It is the second leading cause of cancer deaths, with about 50,000 deaths a year. And there's been a steady decrease in age-adjusted incidence for distal colon, proximal colon, and rectal cancers between the years of 76 and 2005. Most recently, there's been an increase in incidence of colon cancer in a younger population. If you look at the distribution of colorectal cancers upon presentation, you'll see a small portion are in situ cancers, with a very balanced distribution between stage 1, stage 2, stage 3, and stage 4 disease, where stage 4 disease really accounts for about 20% of the diagnosis. So stage 1 through 3 disease is approximately 75% of presenting colorectal cancers, and that's where the role of curative treatment for the most part lies. The risk factors associated with colorectal cancer are many. The largest risk factor associated with colorectal cancer is age. As we get older, we're more likely to get cancers, and more than 90% of cases occur in persons in greater than 50 years of age. But again, there is a younger population that seems to be on an increase that's really not clear what the cause of that is. There is also a risk associated with increased genetic mutations, that which we call cancer susceptibility genes. And this is identified through germline testing and accounts for about 2 to 5% of colorectal cancers, likely more closer to 5%. And we're really only now learning a lot about this phenomenon. Whereas traditionally it was thought that only hereditary non-polyposis colorectal cancer syndrome, or HNPCC, otherwise known as Lynch syndrome, was the most common, with familial adenomatous polyposis, or FAP, being a second. There are many additional cancer susceptibility genetic syndromes associated with colorectal cancer, and including MUTYH-associated polyposis, which is another polyposis syndrome, and POL gene mutations, and GREM1, and it really is maybe approximately 20 genes that can be mutated with genetic syndromes, and now there are panels that really test for all of these when there is cancer susceptibility genetic syndrome that is accounting for the colorectal cancer. So it's not just identified with clinical criteria such as number of polyps and family history, but there really are additional features that test for these, and there might be additional clinical implications with each of these that we'll touch on a little bit later. Additionally, personal or family history of colorectal cancer increases the individual risk, and there are several modifiable risk factors associated with colorectal cancer, including obesity, physical inactivity, smoking, heavy alcohol use, diet high in red meat, our usual American diet, and in addition, inadequate intake of fiber like fruits and vegetables. This is the staging of colorectal cancer. This is something that I know it's expected that you all understand staging of cancer in general, and this is the colorectal cancer staging. It has major both therapeutic and prognostic implications, so it's important to get this right on the front end. If you look at stage 0, that's in situ cancer. Again, that's a very small minority. But generally speaking, there's T stages, N staging, and M staging. The T staging is determined by how deeply through the bowel wall the cancer penetrates. It usually starts on the surface or the mucosa layer of the colon and then invades deeply through the submucosa muscle layer, past the muscle layer, and can also invade into surrounding adjacent organs. And depending on how deeply it penetrates, that is determinant of the T stage. And you can see in the second column, as the T stage increases, so does the overall stage. The N stage accounts for whether or not there are lymph nodes involved and the number of lymph nodes involved. And then the M stage, if it's M1, that's stage 4 by definition. So just walking through the various stages, stage 1 is early stage cancer, where it's T1 or T2 and there are no lymph nodes involved. The treatment for that is surgery, and the cure rate is about 95%. Stage 2 is really separated into stage 2A as a subset, and T3 is where it invades into the muscle layer, and there's no having no lymph nodes involved. In stage 2 disease, the treatment is surgery, and we'll discuss the possibility of adjuvant chemotherapy if there are any poor risk features. But generally speaking, surgery is the mainstay, and the cure rate is approximately 85%. In now stage 2B disease, when there's T4 disease and the cancer is invading through the bowel wall and into adjacent organs, that is coupled with stage 3 disease where the lymph nodes are involved because the prognosis is worse. And generally speaking, surgery for stage 2B and 3 disease, surgery is indicated to treat the primary cancer, but in addition to that, there's a clear role and significant role for adjuvant chemotherapy to reduce the chances of the cancer returning and of it metastasizing and of dying from cancer. And the cure rate for that is approximately 60% or so, depending on what the real stage is and the type of adjuvant therapy. But in general, again, there's a clear role for both surgery and adjuvant chemotherapy in that situation. And stage 4 disease it doesn't really matter what the T stage or N stage is, but there's metastatic disease. That the mainstay of treatment is systemic chemotherapy. Surgery is only indicated really for resectable disease or if you're having problems from the primary itself. But the real treatment is systemic. The mainstay of treatment is systemic chemotherapy plus or minus a biologic therapy, and we'll discuss that more. And generally speaking, the goals of treatment shifts from more of a curative setting to usually a palliative setting unless there's surgically resectable, completely resectable, low-level disease. So again, to summarize, the role of surgery in colon cancer is really in stage 1 through 3 usually, but occasionally in the stage 4 setting. And you can see again the 5-year survival rate following surgery for stage 1, 2, and 3 on the right side of the slide. But high-quality surgery is clearly the primary treatment in this disease. And one of the quality indicators is the number of lymph nodes that are harvested. So generally speaking, only if there are more than 12 lymph nodes found is it a quality surgery. And that's actually a quality metric that's measured usually. So if, for example, there are no lymph nodes involved and only 4 lymph nodes were found at the time of in the surgical specimen, it might be, and it's a stage 2 disease in that scenario, that might be that is a higher risk stage 2 cancer, and that's a different, that might be even a higher risk than someone who has 1 out of 40 lymph nodes found. And so it really, the number of lymph nodes that were found at the time of surgery is an important prognostic quality metric. Additionally, surgically, there are laparoscopy is now widely accepted. So there might be a shorter hospital stay, a smaller incision, and in the skilled hands, the outcomes are the same. Okay, now we'll shift from surgery, the role of adjuvant chemotherapy. So generally speaking, with 5-FU-based chemotherapy, it usually will enhance the cure rate by about, on a relative basis, by about 1/3. But in addition to that, there is an additional survival benefit when oxaliplatin is added to the 5-FU. Now, we'll focus exclusively right now on stage 3 colon cancer. The benefit to oxaliplatin in that situation is an absolute benefit of 10 to 15%. You can see on the right side is the MOSAIC trial where that is determined. And you can see those Kaplan-Meier survival curves where you see the patients that got FOLFOX, generally speaking, there was a higher cure rate than those that just got 5-FU alone. And 5-FU is really, before this, had been the standard of care for over 30 years. So now FOLFOX in stage 3, generally speaking, is the standard. However, there are situations where you need to consider age and comorbidity to see whether or not that relatively small relative impact of 10 to 15% translates into benefit to the individual patient. So if the patient is 80 years old, or if the patient has a pre-existing neuropathy, it may be that the benefit that they get, this relatively small benefit from the oxaliplatin, is not really going to benefit this patient in the long run in terms of the general survival by increasing the risk and side effect profile and decreasing general functional status of the patient with oxaliplatin versus without oxaliplatin. So you may enhance the cure rate a little bit, but not do this patient any favors. So there has to be some individualization despite this data. And in addition to that, there's been multiple clinical trials looking at adding biologic agents like anti-VEGF therapy and anti-EGFR therapy to this chemotherapy, and it has yet to show any improvement in outcomes. So there really is no role of biologic therapy in an adjuvant setting. So if you see it, that being given, question that significantly. Additionally, the question of whether or not to give capecitabine, is that a replacement for 5-FU? So capecitabine or Xeloda is the capecitabine gets broken down in the tumor and microenvironment into the active anti-metabolite that, or the active agent of how 5-FU works. So it's really like giving 5-FU. And this data, the exact trial, shows a 5-year disease-free survival benefit that is non-inferior with capecitabine versus 5-fluorouracil. So that I think you can safely say that you can replace bolus infusion 5-FU with capecitabine in an adjuvant setting. So certainly if you, for those patients that you won't be using oxaliplatin in, it's certainly a more convenient option, a non-IV option, and sometimes more palatable option for the patient to give capecitabine versus walking around with a pump and using infusional therapy. So, you know, if you're just doing 5-FU alone, certainly you can use capecitabine as an alternative. Now, what about the role of adjuvant chemotherapy for stage 2 colorectal cancer? So we know that there is still, in the Quasar study, a small improvement in survival, an absolute improvement of 3.6%, which is certainly, it will get you closer to the 85 to 90% cure rate. Well, here about 80% cure rate with by adding 5-FU-based chemotherapy versus observation in stage 2 colorectal cancer. However, there is no role for adding oxaliplatin really for the standard stage 2 patient. The question is there clearly is a subset of patients that are going to derive benefit from with stage 2 cancer that are going to derive benefit from chemotherapy, and there is a subset that will not derive any benefit from chemotherapy. So the question really is how do you separate out the risk of stage 2 patients, those that are going to derive benefit from chemotherapy and those that will not? So there are several high-risk features in stage 2 disease that tend to select out those patients that are more likely to respond or derive benefit from chemo. So for example, if the low number of lymph nodes were examined, like we talked about before, if there was under 12 lymph nodes, that's a higher risk stage 2. If it's poorly or undifferentiated histology, or if there's T4 disease or microvascular invasion, or there's a recent literature actually this year with CDX2 as a protein that's expressed on a subset of colorectal cancer, where if they are CDX2 negative, they're more likely to respond to chemotherapy. That's an emerging. Those that are less likely to derive benefit with stage 2 disease are more elderly patients, those that are MMR deficient. So MMR deficiency is a very important concept in colorectal cancer that I'm going to touch on. But basically, it's where you have a mismatch repair protein that is not expressed. And that can either be because they have a germline mutation that makes it not able to be expressed, like Lynch syndrome, or they have developed the somatic mutation that makes them not able to express one of these mismatch repair proteins. And when these mismatch repair proteins are not expressed, we know that the patient is deficient in the mismatch repair protein. And in that clinical situation, it predisposes them to developing additional mutations in their cancer. The mismatch repair proteins are responsible. They're the kind of the policing mechanism that the cells use to fix any mutations that happen normally in nature. And when they're missing that, that essentially enables those mutations to not get fixed. So oftentimes, patients that have this MMR deficiency, they get a lot of different mutations that are found in the tumor. But when you do find, and there are clinical implications with that in a metastatic setting that we'll touch on a little bit. But in this kind of a setting, it portends a better prognosis, and actually 5-FU chemotherapy doesn't really work in them, so they're not going to derive benefit. That's a subgroup that when you find it, they really don't derive any benefit from chemotherapy. So it's standard now to look for those proteins in the pathology, just as you look for immunohistochemistry in a lot of different tumor types. This is an important thing to look for because it's better prognostically and it doesn't derive any benefit from chemotherapy. Another test that's sometimes used but not really the standard is looking at gene expression profiling or oncotype, and that is sometimes utilized but it's not fully accepted. Okay, now shifting gears to rectal cancer, I'm going to just very briefly discuss that we, generally speaking, risk stratify the patients into intermediate, moderately high, high risk, and then determine whether or not they should get trimodality therapy. Usually you would give radiation in addition to the chemotherapy and surgery. Now, as a general principle in rectal cancer, what you're looking for first and foremost is to cure the patient. But other important issues that are unique to rectal cancer over colon cancer is trying to spare the sphincter preservation, so that the patient can remain continent, and in addition to potentially spare them a long-term colostomy if possible. And the other goal of therapy is to minimize on morbidity. So generally speaking, we try to employ preoperative therapy with chemoradiation, and in that setting, it enables fewer APRs, or abdominal perineal resections, that basically take out the sphincter and result in long-term colostomy. There's also less toxicity, less local failures, and no difference in distant failures or survival. And this is a NCCN guideline, generally speaking, how to treat rectal cancer, but I'm just going to briefly give the ground rules. Essentially, clinical staging, you do clinical staging on the front end, primary neoadjuvant treatment with either chemoradiation or chemotherapy, then surgery if feasible, if they're a right candidate for surgery, and then additional adjuvant therapy based on the initial clinical staging or what's found at the time of surgery. That's the general guidelines for rectal cancer. Follow-up for stage 2 and 3 disease after curative treatment. So once you're done with either the surgery and or the chemotherapy, general principles, the disease will usually relapse if it's going to relapse within 3 years. Single organ recurrence is an important feature of colorectal cancer, and that's really what you're looking for, is a single organ solitary or oligometastatic recurrence, meaning small, low-level metastatic disease that's surgically resectable. And the reason that you're looking for that is, and that's why you're doing this screening, the reason that you're looking for that is what you're looking for is the kind of disease, if it's going to develop stage 4 disease, you want curable stage 4 disease. And that could be by surgery or radiofrequency ablation, microwave ablation, stereotactic radiosurgery with radiation, in addition to chemotherapy. But you're looking for disease that you can locally treat because it's either solitary or oligometastatic, and then utilize the role of local therapy and chemotherapy to try to cure them again. You get a second chance. So the general guidelines for follow-up, and I'll just talk through the NCCN, is bringing them in every 3 to 6 months for 2 years, and then 6 months for the remainder of 5 years, and checking CEA. And in addition to that, checking CT scans on a every 6 to 12 months for 5 years if it's stage 3 or high-risk stage 2. And then they'd get a colonoscopy at 12 months, at 3 years, and every 5 years. Okay. Now, again, we're going to discuss defective or MMR, or mismatch repair, in colon cancer, again, just because it's such an important feature. And we talked through that before, but we'll talk through it again. It's characterized by either the presence of microsatellite instability that's tested by PCR, or a loss of IHC, immunohistochemistry expression, of the proteins MLH1, MSH2, MSH6, or PMS2. So those are the 4 proteins that are generally tested by IHC in the pathology. And you'll see that on the pathology report. If you don't, then ask, why is it not on the pathology report? And sometimes there's a good reason, and sometimes there's really not a good reason. They just have not done it. So 15% of sporadic colon cancers have this mismatch repair defect, and most of those are usually MLH1 loss of expression. it's clinically correlated with right-sided cancers, in other words, the ascending or right-side colon, female, earlier stage, and better prognosis stage for stage. Usually you can see some bizarre features, including signet ring cells. You also it can be poorly differentiated. You'll see lymphocytic infiltration or near diploid. And it can, generally speaking, because of the fact that you're missing mismatch repair, you'll see more mutation rates. So when you see, there are some poorer prognosis subsets, but generally speaking, it's better to have this, and better prognostically. And the deficient mismatch repair cells seem to be resistant to 5-FU, like we discussed before. So in conclusion, as it relates to adjuvant therapy, again, distinguish between stage 2 and 3. Stage 3 disease, adjuvant therapy is going to be standard in almost all patients. Oxaliplatin-based therapy is the standard. However, there are exceptions to every rule, and elderly or patients with multiple comorbidities may not have benefit from oxaliplatin. In stage 2 disease, you're more selective in terms of who you give adjuvant therapy to. You usually do not give with oxaliplatin except for the highest risk patients, and the standard is 5-FU or capecitabine alone. You have to be aware of cumulative neurotoxicity of oxaliplatin that we'll discuss, and it usually happens after 8 or 9 treatments. You see continuing worsening of neurotoxicity, and there's an additional acute neurotoxicity we'll discuss a little bit. And again, MSI high or mismatch repair defect cancers have excellent prognosis. And molecular signature tests like Oncotype are not yet fully embraced or the standard. However, there might be selective times where you would utilize it. Okay, now moving on to advanced colorectal cancer, we'll discuss first-line therapy. In general, and this is something that every physician, every nurse, every advanced practice provider needs to be familiar with, because before you give any therapy to a patient, it's like a vital sign. You got to know why you're giving that treatment. What is your goal of therapy? And that's always something before giving it you should question in your mind, and you should articulate it to the patient, and you should have it recorded in the note what the goal of therapy is. Is it curative? Is it palliative? So with curative intent is considered an organ-limited metastatic disease. So if there's liver metastases or a lung metastases that could be resected or ablated, that's where you're talking curative goal. However, generally speaking, the majority of stage 4 cancers is palliative, and the goal is improving quality of life and prolonging survival. Okay, the drugs that are used for advanced colon cancer, separated out here into the left column of chemotherapy regimens and biologic agents. So, and sometimes they're coupled and sometimes they're given on their own. So chemotherapy agents include 5-FU or capecitabine. It can be combined with oxaliplatin as in the FOLFOX regimen or CAPOX regimen. The 5-FU can be combined with irinotecan to give FOLFIRI. Additionally, there's FOLFOXIRI, where you give 3 drug regimen together, 5-FU, oxaliplatin, and irinotecan. Mitomycin we won't really discuss, and Tegufur we won't really discuss, mitomycin being an older agent and Tegufur being really only not available in the United States. And TAS-102 recently approved, or Lonsurf we'll discuss. The biologic agents include, and general subsets, and we'll talk about all of these, anti-angiogenic agents, and there are 3 of them, including bevacizumab, aflibercept, and ramucirumab. Anti-EGFR, there are 2 options there, and then multi-targeted therapy, regorafenib. And then there's immunotherapy, pembrolizumab, that we're not going to discuss. However, I'll just briefly say that there is no role for immunotherapy in colon cancer at all, except for the mismatch repair defect or Lynch syndrome patients, where they tend to be very responsive to immunotherapy with PD-1 inhibitors. So this is something that is a very new situation that accounts for maybe 2 to 3% of metastatic patients that might be a candidate for this, and it seems, at least with very early data, to be very responsive to PD-1 inhibitors. But because it's rare and it's emerging data, we won't focus on that today. But generally speaking, with systemic therapy, there's been incremental gains from 6 months with best supportive care to over 30 months now with combination chemotherapy. General rules of advanced disease: there's no predictive biomarker for chemotherapy. Monotherapy with 5-FU or single-agent therapy might be an option for the less fit or elderly patients. Doublets or triplets result in higher response rates. FOLFOX and FOLFIRI seem to be similar in efficacy, so interchangeable, although FOLFOX seems to be utilized more frequently in a front-end agent, maybe because of side effect profile being more tolerable. And then an important concept is RAS-mutated cancers. So 50% of patients will have a RAS mutation, either KRAS, NRAS, HRAS. That's usually detected on a molecular profile that's become the standard in metastatic disease to check for RAS testing. If there's a RAS mutation, they will not respond to EGFR inhibitors. So you're looking to select out those patients that will have zero response to EGFR inhibitors. So if you see someone with a RAS mutation receiving an EGFR inhibitor, question that. The EGFR inhibitors will only work for those that are unmutated or wild-type RAS. So you have to just make sure that there's not a RAS mutation. There is no biomarker to select who's going to respond to angiogenesis inhibitors. The treatment duration is usually either 6 months, or they're given induction therapy for about 4 months, and then maintenance or de-escalation as the tolerability decreases, or they might get cumulative side effects. And then essentially you can de-escalate the dose or type of agents that you're using to really just continue on some kind of maintenance therapy. And generally speaking, we're kind of liberal in terms of if the patient's really not tolerating it well after some time, or they've got some family event, they're going to a family wedding or a family reunion or a graduation, or they're going away to Hawaii or whatever it is, you give them a holiday, chemo holiday, and let them balance out the quality of life that they get from not being on therapy with the quality of life that they get from continuing on therapy. So you have to balance that out. The sequence of drugs may be less important than your ability to enable exposure to all of the drugs, including the biologics. So the reason why patients live long isn't because they get a certain sequence. The reason that they're living longer is because they get exposure to all of the potential therapies that are out there for colorectal cancer. So it's important that at some point in their treatment, they get exposure to each of the therapies that might be that are options in this cancer. Triplet regimen may be the best option for BRAF mutant cancer. So again, you're looking for RAS mutation, but you're also looking for a subset of patients, maybe 10% or so, of metastatic patients that have a BRAF mutation. And the reason that you're looking for a BRAF mutation is because prognostically those patients do not do as well. So those patients may particularly benefit from the triplet regimen with FOLFOXIRI, because they may not get a second chance because the disease usually grows a lot faster. So again, exposing them to all of the agents and maybe giving them all of the drugs up front might be the best option. And here's that data that's based off of, and it's small numbers, but when patients got FOLFOXIRI with bevacizumab or Avastin, in those that had BRAF mutations, they did better with FOLFOXIRI and bevacizumab than with FOLFIRI and bevacizumab. And it looks like the survival was 19 months versus 10.7 months. However, this is small numbers, 28 patients, so it was a trend in favor of the triple drug regimen, but it's enough in the absence of data, it's enough, and knowing prognostically how BRAF mutated patients do, it's enough to consider this in the right patient, certainly a younger patient or someone who can handle it. That might be somebody that would be important to consider. The data using bevacizumab in frontline, in addition to chemotherapy, is quite solid, and that is combined with either FOLFOX or irinotecan-based regimen, showing anywhere from a 2-month to 5 months survival benefit its overall survival benefit by adding bevacizumab or Avastin in the front line. So just to go over anti-VEGF therapy in the front line, the duration of VEGF inhibition matters. It's usually you're treating until progression. You're employing anti-VEGF, or in this case Avastin, maintenance, and in addition there's some data showing treatment beyond progression in second line that we'll discuss a little bit. There's clinical synergy when combining it with 5-FU-based therapy. There are multiple positive trials showing that VEGF inhibition can be treated beyond progression, and we'll discuss the other agents with anti-VEGF therapy in a minute. And it can also be combined with the triplet regimen. It was done in the TRIBE trial. It was done in the STEAM trial that we participated in our institution. Now, going over the data briefly in next line therapy, following progression on Avastin with chemotherapy. So in other words, second, third line data. There's data with Zaltrap and Cyramza, so zivaflivircept and ramucirumab respectively. The Velour trial showed that aflibercept plus FOLFIRI was better than FOLFIRI alone and offered a 1.5-month survival benefit. The RAISE trial with ramucirumab was very similar design and showed the same, approximately 1.5-month survival benefit. And the TML trial in second line combined bevacizumab or Avastin with chemotherapy in second line treatment. So it's treatment beyond progression where they'd previously had Avastin, and also showed a 1.5-month survival benefit. So it seems there are 3 different options of anti-VEGF therapy that can be utilized in patients who are after the front line. And any of these are potential options. It probably doesn't matter which one you give, whether any of these agents can probably be given with the same, relatively same outcome. So that is, so certainly that's a good option. Any of these are good options. Now, moving on to anti-EGFR antibodies. So these are antibodies that are designed to block epidermal growth factor receptor. So these are antibodies that are designed to block epidermal growth factor receptor. It includes panitumumab and cetuximab, or Vectibix and Erbitux, respectively. They are likely of equivalent efficacy. By blocking EGFR, it decreases cell survival, proliferation, angiogenesis, and cell motility and metastases. If there is a RAS mutation, like we discussed, it does not add anything. It really does not work. It has established efficacy in both first-line and subsequent lines of therapy. You can see here that the survival benefit is, it adds anywhere from 3 to 6 months of survival with the different combinations, depending on the study. So there's clear efficacy in wild-type KRAS. And you can see here the incremental improvements in survival over the past decade of trials. And you can see whereas in 2000 the trials were patients with 5-FU alone enabled a 12-month survival. Now with by getting all of the agents in over the lifetime of the patient, even with more recent studies, there's up to 34 months survival benefit in more recent studies to be reported. When looking and comparing whether to use bevacizumab or EGFR antibodies, basically there's pros and cons of each. The benefits of bevacizumab is it delays tumor progression and better toxicity profile, and the weakness is that there is no single agent activity and weak effect on response rate. Whereas EGFR inhibitors, there is single agent activity, there's a consistent increase in response rate, there's activity independent of line of therapy in any line of therapy, and there's a predictive marker being RAS to determine whether or not patients will respond. The weakness is the gain in time to progression is moderate, and the toxicity profile, particularly the cutaneous toxicity with skin reactions, can be very significant. Going over the side effect profile, I will discuss each of these a little bit. Just to go back, talking about oxaliplatin, the unique side effect profiles associated with that. You can get neurotoxicity, including really when you touch cold things or eat cold things or drink cold things. You have to caution the patient not to, even when they put their hands in the fridge, it can cause a neuropathy acutely. And when they eat or drink cold things, their jaw can hurt. They can get wicked brain freeze. So you have to counsel them ahead of time to eat or drink room temperature or warm food or drink through that time. With the neuropathy, staying away from cold, and over time, the cumulative neuropathy can be an annoyance. So sometimes a dose reduction or eliminating, sometimes by giving B complex or a neuroleptic can help. But generally speaking, that's something to consider. You can get nausea, vomiting, fatigue from that, and one of the rare side effects that can happen in addition is a sensation where the patient feels that they're not breathing, but they really are. And that's something that they have a loss of that sensation. And it's just counseling the patient through that, and it's a rare subset that get that. Irinotecan, the unique side effect is really diarrhea, and that's something, antidiarrheal agents that they take on the front end, they have it with them, they take it on a regular basis, and as they need it and stay hydrated is something to consider. When talking about bevacizumab related toxicity, hypertension, wound healing issues are important to consider and monitor for. We also check intermittently for protein in the urine that can happen occasionally, and you have to treat the blood pressure or eliminate the bevacizumab if it's severe. There is also you don't give the bevacizumab if they just had surgery. You usually have to wait 28 days before or after surgery, or for a minor procedure like a port, up to a week or so. And then with bevacizumab, in addition to that, there is one of the things to consider if they call in with the acute onset abdominal pain to look for perforation. That's an important thing to not miss, to bring them in, get assessed, maybe get a scan and labs, and make sure that if there is a perforation, that can be a deadly complication that they need to be addressed immediately, even surgically. So that's something to evaluate. Then that is a rare complication, maybe 2% or so. Then EGFR antibodies, it's very common to see cutaneous toxicity where they can get a rash, acne, subungual kind of roughness or breakdown of the skin. And skin moisturizers and acne treatment is important, either acne cream or oral antibiotics. We usually give minocycline, but that's something that needs to be considered, or a dermatology referral if it's severe. Okay, now moving on. So going beyond second line, that was a little bit of a interruption to discuss side effects of each of these agents, but moving on to beyond second line, regorafenib or Stivarga is an oral agent, and it blocks multi-kinases, including KIT, PDGFR, RET, VEGF-R 1 through 3. And the CORRECT trial is really the what established the efficacy in this. There's extended survival, again, for about a month and a half, from 5 months to 6.4 months, as with any of these VEGF inhibitors. This does have hand-foot toxicity, and you can see occasionally severe, where you need to dose alter this. And usually we would start at a lower dose and dose escalate in order to enable them to not get the kind of side effects that they might. You can get fatigue, hypertension, diarrhea, rash and desquamation, anorexia and mucositis, and sometimes some voice changes. Bleeding, as with additionally with Avastin, you can sometimes get nosebleeds and rectal bleeding sometimes. But you can get this also with the Stivarga as well. You can also get some nausea. But again, so you're seeing that toxicity profile with the additional benefit. And then additional agents beyond second line include Lonsurf, and this, or otherwise known as TAS-102. It's a nucleic acid analog that is the active cytotoxic component, and it's got complex dosing that you can see is 35 milligrams per meter squared twice a day on days 1 through 5 and day 8 through 12 of a 28-day cycle. It extended survival from 5.3 months to 7.1 months compared to placebo. And you can see here the side effect profile of Lonsurf, with nausea, vomiting, being generally manageable. The grade 3 toxicity is not that common, 2% in each of those. Decreased appetite, again, usually mild, usually some mild fatigue and diarrhea, usually some, if they're going to have abdominal pain and fevers, usually mild also. Small subset of patients get febrile neutropenia, and 8% get some stomatitis. There is neutropenia, and 38% will get grade 3, but again, the febrile neutropenia rate is only 4%. So there can be an effect on blood counts, a small increase in liver function tests. Here are the take-home messages from what we've talked about today. So first, always identify the goal of therapy. For most patients with metastatic disease, a gain in time and maintaining quality of life is most important. The bevacizumab is important for patients that are candidates for it, and duration of therapy is important. The response rate, so generally speaking, the survival and quality of life is most important. Response rate plays a role when you're trying to convert a otherwise unresectable patient into a resectable patient. So you're trying to convert that which was thought to be non-curable metastatic disease into a curable metastatic disease. That's where response rate really plays a role. And if the patient also, response rate plays a role if he's pre-symptomatic, he or she is symptomatic from his tumor burden. Usually you will treat to progression and beyond, and be mindful about the toxicities for example, stopping oxaliplatin before neurotoxicity develops, long-term neurotoxicity. And the important other principle is to expose patients to all the potentially active agents. Use all of the potential tools to keep the patient alive. Use fluoropyrimidine-based backbones as the default backbones, and reserve sequential single-agent therapy for select patients. But usually you have the 5-FU backbone with additional chemotherapy and a biologic as your go-to combinations. We have new active agents, including aflibercept, regorafenib, TAS-102, or Lonsurf, and that summarizes the talk for today.